Good evening, everybody. We started the statutory 5 minutes late to let everyone come aboard. And welcome to the second of our series of 3 webinars. Hopefully some of you joined us last week. Don't forget we have another one this time next week, which is orientated towards patients and families. But tonight we have a very good distinguished audience for what's called a virtual roundtable. And the title tonight is Access and Ethics, Medical Cannabis Perspectives. So we have, as a very good panel. I think it's probably easier if I introduce people as they come on one by one, as it were, rather than introduce everyone at first, like we did last week. In terms of timing, we have till 7:30. I'll try and finish on time. If you've got questions, please just put them on the chat function on the screen. If they're very relevant to that speaker, we might address them at the end of the speaker, but preferably, if they're general questions, what we'll do, I think, is get the speakers to talk for between 5 and 10, 12, maybe 15 minutes each, taking up maybe up to an hour. And then that gives us a good half hour for questions, and we're trying to get all the questions through. We got through all the questions, about 45 of them last week, and we only overran by 10 minutes. So please feel free to answer, and we'll do our best. If there's a few questions that are sort of quite specific, we might have to answer them offline, but otherwise we'll do our very best to answer them all on the end of the webinar. Those turning on may be disappointed that I'm not Danny Gordon. Danny unfortunately couldn't join us tonight. She was going to moderate this session, but I've been asked to. Danny, I'm afraid, couldn't join us at the last minute, which is fine. So I just, a couple of thanks before we start is, first of all, this is a joint project between the Medical Cannabis Clinicians Society, MedCann Support, and Matt, who runs MedCann Support, is going to talk to us tonight on number 2 on our list. So I'll let Matt introduce himself, but many thanks to MedCann Support for working with us to get this done. Thank you, Matt. And then more particularly, as last week, many thanks to Evan. Evan Lewis talked to us last week from Toronto, and he has been also very instrumental in helping us get this together. Many thanks to Evan, and also behind the scenes, as it were, the Jamaica Medical Cannabis Corporation has very kindly supported this for us. So many thanks to them. And thanks to the speakers for joining us. So I'll stop thanking everyone like the Oscar ceremonies and get on with it. But you've got, before I go to the speakers, you've got to put up with me. Well, that's me. I don't know why I didn't put that up first. In just in case you don't know, that's me. And I'm chair of the Medical Cannabis Clinicians Society, which is why I'm speaking to you. Sorry, bear with me a second. I just going to talk to you about the Medical Cannabis Clinicians Society, which was here and of course now isn't here, which is very annoying. So the Medical Cannabis Clinicians Society is just a plea to join that. The website is at the bottom there. And what we do, just very briefly, for the society is open to any clinician. It is the UK Medical Cannabis Clinicians Society, but actually I think we're going to, as we said last week, we're going to have to change that because we now have an international membership, which we're very pleased to do. And last week, I think one of the takeaway messages, we're going to make it the World Medical Cannabis Clinicians Society. We haven't actually done anything about it in the last week, but we hope to. So please feel free to join it. And what it offers is education and training. We're now doing a bi-monthly training session, mainly skewed towards doctors. On the website, we have prescription guidelines, how to prescribe, again, mainly UK orientated. We have the suppliers that are in the UK. We have the clinics in the UK line there. We have very useful for doctors and prescribers to have an online support mechanism through Google Groups. So if doctors are worried about prescribing, we can tell them how to help them, guide them from those already prescribed, both nationally and internationally. We're just about, probably the next month, launching a research and evidence hub, so you can click on it and see what evidence there is for prescribing in, say, Crohn's disease or epilepsy or pain or whatever it is, which I think will be very useful for people. Please feel free to join. I'm sure Matt, will have to say for those parents or families that are there tonight, perhaps you would want to say later on, Matt, when you come into your talk about the MedCann support group as well, which is obviously more orientated to patients and families than the society. So that's my sales pitch about the society. It's £90 a year, very good value. I'll say that 2 or 3 times. I got that in 2 or 3 times during last week's seminar, so I'll probably see if I can get it in 4 or 5 times this time. So that's it. And I'm just really going to next is just to pass over to the first speaker. We're going to have, first of all, the patient perspective on accessing medical cannabis, which after all is the most important thing. It's the patient's or the family or whatever it is, perspective of how this is working for you as an individual. What can we do better? What are the problems you faced about getting access? And we're going to have 2 people there. Dom, who's a user himself, who's been through the clinics, but he can tell you his story in a moment, and then followed immediately by Matt, who's the parent of a child with epilepsy from a slightly different perspective. And then we're going to move to Liz to tell us about her perspective as a prescriber in the UK before we go on to Bonnie and Evan, which I'll introduce later. So I'm going to stop talking and pass over, first of all, to Dom for a few minutes to tell us about your experience and how the difficulties or non-difficulties you've had about accessing medical cannabis for your problems, Dom. So can I pass over to you?
Absolutely. Thank you very much, Mike. Right, so I've been taking medical cannabis for, it's over a year now. And as a result, I've been off opiates since, I've got a date somewhere, I think it was September 2019. And that's after sort of a decade of using opiates. I've written up some notes just to keep everything in sort of a rough running order. So essentially, I was diagnosed with a bulging disc L5S1, which presented as a flare-up where I couldn't walk, I couldn't go to the toilet. It was really, really bad, and I had sort of about 3 flare-ups. This was sort of about 13 years ago, approximately. And off the back of that, I've had this ongoing chronic pain condition, and I've seen to date, over this decade, I've seen numerous doctors, numerous pain specialists, physiotherapists, an osteopath, and so on and so forth. I've been prescribed physiotherapy, paracetamol, ibuprofen, naproxen, pregabalin, gabapentin, duloxetine, diazepam, amitriptyline, prednisolone, codeine, tramadol, and towards the point where I said this is enough, morphine. I've self-treated with back and shoulder supports, martial arts, yoga, weight training, high impact interval training, regular exercise, walking, cycling, just normal working, a TENS machine, an inversion board, hot and cold compresses, tiger balm and deep heat, trigger point therapy and acupressure, and the osteopath. I have been looking at potentially doing acupuncture, but I haven't got around to it. So basically, once I reached the morphine stage, again around sort of September 2019, I made the decision that opiates weren't the way forward. And at the time, I tried very expensive, high-strength CBD oil. It was just sort of over-the-counter stuff. It didn't work, and a friend suggested I try the full-spectrum cannabis, which was it contained THC. It was illegal, I have to add, but it worked. My pain levels were just completely diminished by cannabis. So basically, I sourced an illegal source of high strength, good quality cannabis from a colleague who I worked with in the software industry. And then said about, I mean, it was nonsensical to me at the time that, you know, they were happy to give me tramadol, they were happy to give me morphine, they were happy to give me codeine, yet cannabis wasn't even an option. So basically I saw 2 doctors, a pain specialist, and all 3 basically said, yeah, if cannabis works, it's the right way to go, and it's certainly the lesser of all of the you know, the things you've been given, as far as, you know, risk profile is concerned. But none of them could help. As I'm sure you're all aware, they need to be on the specialist register. So I did some more research, and Professor Nutt's 2021 project sort of popped up on the search, and I signed up for that, and then made contact with one of the, I think it was one of two clinics that were operating at the time. It was kind of serendipity, really. I just did this research, you know, shortly as the 2021 project was in its infancy, before it was even launched. So, and then, anyway, I went to see this, went to see the clinic, because up to that point I'd been essentially experimenting with dose sizes to try and emulate the opiates, what I could have sort of termed the body feel, without getting all of the side effects like the euphoria and all of those bits. It wasn't ever with a view to get high. It was purely with a view to manage my pain. So anyway, I weaned myself off the opiates using cannabis, and I've weaned off opiates a number of times over the course of a decade, and this time there were effectively no withdrawal symptoms. You know, normally I'd have aching muscles or sweats and that sort of thing, but it would appear that cannabis helped ease that transition. I'm not a scientist or a medic of any sort, so I won't go into the physiology because I genuinely don't know, but it definitely helped. So I've seen these two doctors. Right, yeah. So in order to go and see the specialist, I had to fill out a data subject access request form, and then get them to give details of my pain condition going back the last 10 years. And then I sent those on to the specialist. I got an appointment through, and this was a little bit before lockdown. In fact, a fair bit before lockdown, January, I think. Anyway, the long and short is, it was an hour and a half meeting with the doctor, who's I believe he's a cancer pain specialist by trade, so to speak. So he was very understanding, and one of the biggest concerns I had, and I've hit this with pain specialists on more than one occasion. I think they're kind of looking for compulsive drug seeking behaviour, and I completely understand why, because obviously, you know, you don't want to be fueling someone's addiction, but at the same time, it's almost as if that's their default, whereas with this doctor, that didn't seem to be the case. It was, and I had to make it clear to him that it was compulsive drug seeking, because I had the choice of addiction, spinal injections, surgery, or cannabis. And I think really it's, to me, it was a no-brainer. So anyway, so I went to this appointment. I had to wait 6 to 8 weeks for the medicine to be dispensed, because there were license issues. Again, this was a lot earlier in the process, so a lot of these supply line snags have since been ironed out, and I'm aware that there are substantial stocks of these medicines in the UK now, in quantity. I'm led to believe, and from what I can gather, supply lines have been expanded to other countries as well, so that's sort of more stable. But there were gaps in between prescriptions, but it was also made slightly more difficult because I had to titrate up to a therapeutic dose, and quite rightly. But I'm now on a therapeutic dose. It's high strength THC oil, and I'm taking that 3 times a day. I think it's 20 milligrams THC per milliliter, and since I've been taking that, it's I mean, to put it bluntly, there's a profound difference between when I'm under the effect of cannabis and when I'm not, in terms of the pain that I experience. And that's all I need to know. As from my perspective, I don't care about anything else. My pain is managed. But there are aspects to this that, I mean, because it was so difficult to initially get to the point that I'm at, and indeed expensive, I made a point of signposting to as many people as I can via my blog and Twitter and so forth, just to let people know, because I'd spoken to pharmacists who weren't aware of the change in prescription law in the UK. One in particular was adamant that that it was still illegal. You couldn't get prescriptions for it, and that he was managing the Tesco pharmacy in my hometown, and the disinformation and sort of lack of knowledge that surrounds cannabis is it's definitely a problem, certainly a problem to access. Subsequently, once you've got the prescription, you've got things like the legal fallout and so forth, from the likes of the police not having the relevant training and so forth. But I mean, it's not like I'm out in the streets smoking cannabis or anything like that, because I'm not. But there does definitely need to be some more education. I'm doing everything I can possibly do as one human being, but I think things are definitely going in the right direction as far as that's concerned. So the cannabis oil I'm taking at the moment, if it's of any use to anyone, is that I'd liken it to the pain management of amitriptyline. In so much as I'd say it probably reduces my pain levels by about 70 or 80%, as did the amitriptyline. However, the amitriptyline caused me to have cognitive issues, so I wasn't able to continue with it because I wasn't able to function as a normal human being. I found it very difficult to articulate for a start, so working became problematic. So I had to come off amitriptyline, but that was very, very effective for some years, and I see cannabis as a almost complete replacement for that. But since I've been on it, I have been. My pain has been completely managed. It's changed my life, quite frankly, and that's really where I am at the moment. The hurdles I had were, I mean, they weren't terrible, but I think someone without money or without access to at least modest funds would be excluded from medical cannabis, quite frankly. It is a two-tier system at the moment, which troubles me, because I'm a great believer in the NHS. So that's kind of one side of things. But there's not really much I can do in terms of changing the law or anything like that. So I just, or indeed changing the NICE guidelines. So I just sort of keep chipping away and telling people on Twitter, particularly chronic pain patients, that in the UK it is possible to get a legal prescription for medical cannabis. Especially, I get the impression that there's an impetus to sort of remove things like opiates and so forth from standard pain management practices. But again, I'm no expert on that side of things, and I'm kind of insulated from it as well, because I'm not reliant on any opiates.
Okay, Don. Thank you very much for that. That's a lovely start about the issues, and I think the biggest issue in the UK, as you pointed out, is the fact that it's really effectively available through the private sector, which I think is a major ethical problem, mainly due to the intransience of some of my medical colleagues. But it's now not the forum for me to prattle on about the intransience of my medical colleagues, so I shall pass on to Matt. Matt, hi. If you have introduced yourself, if you want to just say a little bit about MedCann support, and again, thank you for being part of the triumvirate that's put this together, and tell us a little bit about your story. Pass over to you.
Cheers, Mike. So basically, we are MedCann support. I run that in collaboration with Hannah. So basically, it came about from both Hannah and myself being parents, and kind of starting out using cannabis. And we found that both of us were getting, and many other parents as well, we're getting lots of messages, and how do I, where can I get CBD from? What interactions? So just lots and lots of questions, and we found we were repeating ourselves. We felt there was a space to have a hub, like a central place for education. So both when we started out using cannabis, I had to Google it, and everything, it was spread all over the place, and it could be some information in Canada or in America. and not much in the UK. So we really felt we needed to kind of centralise it, bring studies, the education, and have the central hub. So it's basically www.medcannsupport.co.uk, which is the website. And then we have a Facebook group as well, which is private. You can just search for MedCann on prescription. And in there, we just have lots of parents. I think we're over 300 now. Families where you can just talk, so, you know, ask questions about cannabis, interactions, and just epilepsy in general as well. So, you know, there's some parents that have recently been prescribed antibiotics. So they ask the question, does this interact with CBD? So again, lots of us are then searching and trying to find the answer. And we have doctors like Evan, yourself, Mike as well, who kind of help as well. So we can kind of lean on other people to get that information if we need to. So tonight I just want to talk about the struggles that we found as a family and as pediatrics, essentially, in the UK. So kind of not just my story, but my son, but I want to kind of how we found, what everyone has found, the, you know, the struggle with the NHS and what is happening in the private sector. So I'm just going to share a PowerPoint presentation. Is that working?
Yeah, takes a minute, Matt, to come on, doesn't it?
Can you see that?
Yep. Thank you.
Right. There you go. Right. So basically in the UK, so this is from Young Epilepsy, which is a charity based in the UK. So it's approximately 37,000 that have children who's under 25 to newborns that have refractory or pharmacoform or uncontrollable epilepsy. So with a population of over 60 million, that's a tiny, tiny number that we have. So I just wanted to kind of bear that 37,000 number in your mind for the moment. So NICE is one of the fundamental overarching organisations. So basically, NHS is a public funded body, and NICE is there to make sure that public spending is correct, that medicines are, you know, you get value for money, and that they're working well. So with regards to cannabis, when they started initially bringing the guidelines together, so the government, when they legalised it, they went to NICE and said, can you put some guidelines together? So as you can see, they looked at over 19,000 sources of evidence. They narrowed that down to 9,000. 38 of them studies were then reviewed against their inclusion criteria, and only 4 of them, which were predominantly the Nhs Trials, were, you know, okayed and added to the evidence. Then there was 4,000 observational studies. Again, this is on CBD and THC, and then 11 were subsequently used as evidence. Basically, the outcome was that recommendation for full extract cannabis-based prescription medicines was essentially there was not enough evidence. So there was prescription for, or they gave the OK for Epidiolex, for Lennox-Gastaut and Dravet syndrome in combination with clobazam. But with regards to full extract oils, at the moment, it's literally, you know, we're waiting for randomized controlled trials and stronger evidence. Now, earlier this month, they did release a statement basically saying that they're now looking for broader data and applied analytics in the way that they process and look at evidence, which is promising. And hopefully, so I think since last year, we're now at 34,000 across the world. This is forms of evidence in full extract. So we're hoping that they may start looking at some of that. Drug Science have recently released on the 10 endowed pain children as well. So again, I hope they take that into consideration. The next kind of problem that we've had, and it affects both the NHS and the private sector, is the BPNA. So in the UK, all 150 paediatric neurologists are a part of the BPNA. It's a charity, and the clinicians sign up to that charity and they pay a fee each year. Again, government approached them with regards to guidelines for clinicians, so for neurologists and paediatric consultants to prescribe. They've basically extended the law, should I say, to allow only paediatric neurologists to prescribe. So although the law says that anyone on the specialist register can prescribe, so in our circumstance, legally, Charlie's paediatric consultant can prescribe, but internal guidance is saying that he can't prescribe and it has to go to the epilepsy centre in that region. So for me locally, that's Addenbrooke in Cambridge. So again, it's only the neurologist that can prescribe. They then set out their own guidelines as to prescribing. So basically, have you failed two or more anti-epileptic medications, primary ones? Then have you responded, or have you responded to ketogenic diet, or you might not be suitable for it? And candidates for epilepsy surgery. And again, if you failed the surgery or if you're not a candidate. So they're the three points that you have to meet before they'll even consider cannabis. Now, my son does meet them 3 points, and many, many other children do. And again, they're still not prescribing cannabis. So then recently, we had the Refractory Epilepsy Specialist Clinical Advisory Service, or REDCAS for short. That came about from Endowpain, so not last year, the year before. We joined many families, 20 families in London, and it was speaking with MPs and Matt Hancock about the blockages and the fact that there were no NHS prescriptions. So Matt Hancock, the Health Secretary, asked for a review. That review took place and they interviewed the 20 families, they interviewed the clinicians as well. And they came back with a set of kind of guides which they felt would help to kind of unblock the current blocks that we had back then. So this is how REDCAS came about. So the way that happens is you have a referral from the paediatric consultant in your local authority that kind of covers neurology. They don't actually see the child, so it's basically the whole case, the medical documents, etc., get sent to REDCAS for a review. And then the clinicians, so we've recently done this for our son Charlie. We had 11 neurologists, they were all a part of their BPNA, and they reviewed Charlie's case. They came back basically saying that there was not enough evidence for safety or efficacy on using cannabis, and offered or recommended that he used 4 anti-epileptics, 2 of which he's already used and failed, 2 he's not used as yet. We are now starting 1 of them just to see, and so far it hasn't done anything. So again, it raises questions about their criteria. So there was a high-profile case recently in November of a family who were recommended the whole plant extract, but there are many other families. There's another family again that are quite well known, whose son is been seizure-free for well over a year now on full extract cannabis, and yet REDCAS felt that it wasn't appropriate and that he shouldn't be prescribed that medication. So you've got to question what, when there's such strong evidence in individual circumstances and cases. So my son is 85% seizure reduction and a much, much better quality of life. So, it's down to these individual cases and not population-wide cases. So at the moment within the NHS, there's 100 prescriptions for Epidiolex, which is a CBD isolate, and there are only 3 NHS prescriptions for the unlicensed full extract oils. 2 of them are MedCann or Vegelite, and 1 I think is from Aurora. So the question is, how do we then start building that evidence base for unlicensed prescriptions? So basically full extract cannabis or botanical oils don't lend themselves to randomized controlled trials. So this is, again, it boils back down to the BPNA wanting randomized controlled trials. So they, are they asking that we isolate each individual compound, we then run each of them through a randomized controlled trial, by which time all of us watching this would have passed away, because that will take 100 years or more. And the amount of money involved in doing that is astronomical. So again, MedCann and many others feel that they should be treating full extract cannabis as a botanical and use observational trials and open label studies to build that evidence, and the individuals as well start doing case studies. So there are NHS trials due this year on the NHS. So it's going to be a THC isolate and a CBD isolate, but it's going to be two controlled groups. So they're going to compare the two. So it's similar to the Epidiolex trial, but there'll be another group with a placebo testing CBD and THC isolate. The idea again behind this is to bring confidence to clinicians on the NHS to better understand THC, but to give them confidence in prescribing. Again, it's an unlicensed medication, so I'm not entirely sure, or sorry, medications that we use are still unlicensed. So if this particular oil or oils work out and they get licensed, then yes, they can be prescribed. But unlicensed medications, is this really going to help? There's lots of question marks over, how effective these trials are going to be. They are a good idea. I think they should be going ahead, and we do need that extra understanding. But the idea behind it is to help clinicians prescribe unlicensed medications, which again, I don't think will happen. So private sector, you can see that adults, there's 5 clinics and 40 prescribing clinicians. And pediatrics, currently there's only 1 clinic now that's actively prescribing. So there's 2 neurologists prescribing, but one's now, her books are now full, have been for over a year. So for new patients, there's only now 1 clinic available in the UK, which really is a bottleneck. So again, if I go right back to the beginning of the amount of children that could potentially benefit from full extract cannabis, this is only going to drive them to the emerging grey market and the black market. So again, we need, and again, it goes back to the BPNA. So because neurologists aren't coming forward to prescribing cannabis, initiatives like Project 2021 and other initiatives are finding it really hard to find clinicians to prescribe. The clinics are finding it really hard to find clinicians to prescribe as well. So again, it's all reduces access for pediatrics. Again, I think it's a combination of lack of education within the BPNA, stigma and fear. So again, BPNA always talk about the fear of THC in the developing brain. Yet if you look at the combination of anti-epileptics, the seizures, and the impact they have on the brain, it's that balancing act. And I think they get confused with the recreational market and the medical, and the studies of both. So again, I kind of wish they'd reach out to people like Evan and Bonnie, who both have really good experience, and kind of get that understanding. And so until that education happens, I don't think we're kind of stuck in this stalemate at the moment. Regarding research and development, so Dr. Richard Huntsman last week mentioned that Canadian pharmaceuticals are finding it hard now to fund oils for studies, especially in rare epilepsies. And again, there's a narrow scope for source of income for open label studies. He did mention that the one that he did run was 250,000. So again, in the UK, with emerging UK cannabis pharma, we don't have the investments yet. We're very new and still in our infancy. So there isn't the funding coming forward to, for open label studies and to bring that evidence base forward. And again, childhood epilepsy at the moment in the UK only makes up 1% of all prescriptions. So for pharmaceuticals, it's a low return for kind of the expense needed for research and development with regards to prescriptions. And again, the cost for parents is going to be higher due to the lack of prescriptions. And that is it at the moment.
Okay, lovely. Matt, thank you very much. That's a very, again, useful summary. If you could unshare your screen, that's great. And I think it highlights that one of the real issues is trying to push cannabis down a pharmaceutical route, pharmaceuticalizing it, if that's a word, is pushing the proverbial round peg into a square hole or the other way around. It doesn't fit. And the people in NICE, for example, are pharmaceutical orientation. So what they came out with was blooming obvious. And then you set up something like ResCAS with people who are overtly and publicly stated they're anti-cannabis. So it's not surprising you had anti-cannabis sentiment. The BPNA is a total waste of space. Wow. And it's time they all resigned.
Totally agree with you on that, Mike. And I think what I just want to say something very quickly. Thank you, Matt, for that talk. But it comes through so readily for me is that there's no patient focus here. It's all about pharmaceuticalizing this plant. And what about my child who's having hundreds of seizures every day? It's absolutely disgraceful as far as I'm concerned. Every child should be treated holistically and individually and looked at. And actually, if they've proven that cannabis works for them through the private sector, then it should be available on NHS, simple as that. As you say, Mike, we don't understand the decision-making criteria. So at the moment, you can submit papers and you have no clue what their decision-making criteria is, which is deeply unprofessional. And actually, you'll never make the grade if you don't know what the decision-making criteria is. So there is real problems. And as Matt and I have talked about, it's actually sadly worse than it was 2.5 years ago at the moment for children with epilepsy, which is incredibly sad. But I know with the Society and with MedCann and with all the wonderful people here, we're going to try and make that better. And we must, because
we must.
Chronic epilepsy is horrendous for families and children to live with, and we must do all we can to make it better.
So let's thank you, Hannah. There's a few brave. There's about, I think Matt said on his slide, there's about 40 doctors now prescribing in the UK, give or take. And we're going to now hear from one of them. And they're pioneering doctors, I have to say. Brave is perhaps an overused word, but there are people who've stepped up to the plate and done the right thing for their patients and not the right thing for their society or whatever. So one of those I'm very pleased to introduce is Liz Iveson, who can introduce herself. I think you're geriatric originally, geriatrician, not geriatric, geriatrician in stroke medicine and neurorehabilitation, and now cannabis, amongst other things. So Liz, perhaps you could tell us about your journey, about how you wanted to prescribe and the problems and barriers and ethical problems you've had in getting to where you are today. And thank you for getting where you are today, incidentally. I'll pass over to you. Thank you.
Okay, thank you, Mike. And thanks, Matt and Dom, for your really informative and educational talk, as it just highlighted the problems very clearly. And certainly, from my perspective, a lot of the points that you've made are exactly what I think are the root causes to problems with access. I think if I was asked to give this talk 2 years ago, the problems with that would be very different reasons. I mean, my sort of cannabis journey, as you like, started just over 2 years ago, and it was a conversation with Mike and a conversation with one of my patients who has a high spinal cord injury, who was self-medicating cannabis for pain, and it was the only thing that he'd found that helped his pain. But he was sending his grandparents to basically troll around the parks of York trying to find a device for this. And certainly that to me just felt completely wrong. But one of his off the cuff comments at that time was, oh well, loads of people take cannabis for pain and it works. And so that that got me thinking, well, as a clinician, I need to at least know a little bit about this. And it was exactly about that time where then the guidelines and the schedule changed for cannabis, and it became doctors on the specialist register to prescribe cannabis. But I think at that time, I knew nothing about it other than the fact that I spent 2 years in Jamaica doing a research project, and the only time I'd seen cannabis was really people smoking it on the beach or at university. I've had no personal experience of it whatsoever, and I had a very negative connotation of it from the point of view of my cousins, so some family members and have actually ended up in hospital because of it. So I've come very sort of full circle round with my knowledge of cannabis. So So at that time, there were no clinics open, there were no doctors prescribing, and I met Hannah and Mike and became and basically self-help educated about it, and ended up going over to Canada and observing a Canadian physician who was prescribing cannabis there, and really got some hands-on experience of actually prescribing medical cannabis. So the access, the barriers to access 2 years ago were very much there was no clinics open, there was very few products in the country, and there was, there were very few doctors that were willing to prescribe it, and a lot of that was education as well, and just not knowing and understanding. Because one of the big problems I feel as a medical profession, as nurses, as healthcare professionals, we're not taught about medical cannabis at medical school. It's not in our curriculum, and normally when you're a doctor training, you go and sit in clinics, and it's sort of, you learn from watching your peers do something. And still, we're a lot further on now than we were, but at that time there wasn't any of that I could actually go and find out more about it. So fast forward, over the last few years, I've become obviously educated in cannabis. I've prescribed cannabis to hundreds of patients now, my knowledge base has expanded a lot, and a lot of what I do now is try to help educate doctors and promote awareness of it. So I think some of the barriers in access to medical cannabis have been improved, particularly for adults. And I completely hear what you're saying, Matt. I think the situation that parents of children with is just awful. And I think the fact that clinicians don't acknowledge, or not clinicians, but the NICE and commissioners don't acknowledge the N=1, or the power of actually an individual person's response to a certain drug, and acknowledge that, and then take that out. It's very poor, really. So I think things have improved from an adult point of view. So now we have processes in place. So there's clinics open. There are products in the country, as Dom said, and that initially, when I first started, I had an incredibly limited amount of products that I could prescribe. Whereas now, certainly in the last maybe 4 months, there's been a massive improvement in that. So now I prescribe medication that I think would work for that patient and really optimize their symptom management. And there are more doctors available to prescribe, and people can access it. I think talking about purely the private sector at the moment, obviously one of the biggest problems is cost, and I see a lot of patients that have bought it on the self-medicating cannabis. But then, want it legalized, want it prescribed properly, want to know what they're having, want to have it overseen by a doctor that can really optimize their control. But then when you start talking about maybe an oil to take during the day, a THC type of oil at night to help with sleep and pain at night, and then you add in some flower for breakthrough pain, which is how I tend to prescribe generally, the cost is still, hundreds of pounds a month. And that's even on Project 2021. So I think there are some of the barriers significantly over the last 2 years were a long way. I'm involved. I'm on the scientific oversight board for Project 2021, and was involved from the very start of helping set this up. And I do think there's access. I think trying to collate some real world evidence and some really and observational evidence of side effects, benefits, risk, people that have had reactions, and all of the symptoms that are being collated in Project 2021, I think is absolutely key. But the other thing that really has made a massive impact from my perspective is just patients being able to access some cannabis. But I do find it has been quite difficult sometimes to, as a prescriber, not be able to prescribe what I would want to prescribe because I'm aware that my patient cannot afford what I would want to prescribe to minimize the symptoms. So I think there have been some improvements, but there's a long way to go. Obviously, that's in the private sector, but then we want access to medical cannabis for patients that have met a criteria, and we think that it will be suitable for within the NHS as well as the private sector. And it really boils down to sort of three main things. So I think the first thing is education. So I think education, and that needs to be education from in all areas. So from the ground up, from professionals and people that are actually going to do the prescribing. So medical schools, nursing colleges. I think people need to understand about the endocannabinoid system. They need to understand about cannabis itself. And the stigma needs to be taken away from it. And even if they then do not go on to prescribe, core understanding of actually what it can do, types of people and symptoms that it might be able to help with, is absolutely key to get the general stigma taken away from cannabis. And it needs to be viewed very much as just another drug or another medication that we have in our repertoire of medications that I can look, and when I individually assess a patient, I'm aware of what it can do. And then even if I don't go on to prescribe it, at least it's there and it's within it's on people's radars. So, and drug science and other groups that I'm working with that is starting to filter through now. So there are some medical schools that are now starting to teach about the endocannabinoid system. Obviously through the MCCS, which I'm on the executive board as well, we're trying to do a lot of education and training. And I think a lot of this is just about educating people and talking about it more. Yes. And I have spoken at the Royal College of Physicians meetings. So it is getting more into the mainstream. So I think that's the first thing. Yes. The other thing is just, again, education of the general public regarding cannabis, because there is still a big stigma around this. I've had patients who have taken their cannabis products into hospital and been told, as Dom did, that this is an illegal product, you can't have it. They were then left in pain because they didn't get prescribed an alternative. And there is didn't dare vape their cannabis in front of people because they thought they would either be arrested or looked down on. So I think there's a stigma point of view, and it all comes down to education. And then the other massive area is the research. And if we can get good quality research done and get NICE and the professional bodies to recognise that they cannot expect randomised control trials with medical cannabis. The cannabis itself isn't a one molecule. You have to titrate it up, so you can't have blinded trials. And also the patients that you're managing, their symptoms are so many different symptoms, and everyone's pain is very different, and so actually it's very difficult to do randomized control trials of X versus X. And I think in rehabilitation medicine, which is what and stroke medicine, again, it's very hard to get rehabilitation trials because there's so many different aspects of different outcomes. So having really solid world sort of databases and the recognition of qualitative and quantitative studies, studies of A and B and A, so a group of patients that are on it and then off it and then on it again, all those will help boost the evidence up.
Yes.
And it's nice to recognise this. And then I think if we can get the evidence robust enough that the professional bodies recognise this and therefore the guidelines change, then I think that will open the door to much, much better access. Because I think one difficulty at the moment being a prescribing doctor is you do feel it is quite an anxiety-provoking time at the moment. I mean, everything for me is that everyone prescribes loads of unlicensed products all the time. I mean, a lot of pain medications are unlicensed for the indication. I mean, amitriptyline for sleep, for example, is an unlicensed product. But because of cannabis being called cannabis, it has this stigma associated with it. Whereas if we can get the evidence in the professional bodies to say, even if they don't say, you know, go off and prescribe it, even for, you know, people with specialist knowledge and, you know, can prescribe it, I think it just will open up the access a lot more and have those conversations.
Yes.
So,
okay. That's Liz,
from my perspective.
Yeah, great. Thank you very much, Liz. That's very helpful. Put it in a UK perspective, but we're now going to move on to an international perspective. And Bonnie, first of all, thank you very much for joining us. Thank you very much. You're well known globally now in the cannabis space. You're medical director of the Cannabis Centers in Los Angeles. And of course, we should recognize in the UK that we're years behind not only Canada, but actually California, Colorado, and other parts of the States have been doing this for a long time. So you have a lot of experience, and we'd love to hear your views of these issues from a American perspective. So Bonnie, thank you very much. All yours.
All right. Well, thank you for having me. Can you hear me okay?
We can, thank you.
Okay, great. And thank you to MedCann for inviting me and for really leading the way in the UK, as well as these other groups that are involved. I'm going to make a bold statement, but I don't think it's anything that anybody here would argue with. It is cruel and inhumane to deny cannabis medicine to people who are suffering with severe and chronic illnesses, who have tried the conventional path and have not found success. I do not understand the idea of hanging on to, no, you can't have it, keep trying what doesn't work. It makes no sense to me whatsoever. And in the meanwhile, parents like Matt and Hannah and patients like Dom are left to their own devices to try to either break the law for their loved one or for themselves, or to try to figure out a way to get through life day by day with this ridiculousness that comes from propaganda that was generated back in the 30s and 40s that had nothing to do with the science. And now we are demanding that cannabis, which is not a pharmaceutical, fits a pharmaceutical model. And there's a real problem with that. I know someone asked a question, why can't it, why is there a problem with, you know, why can't it follow the pharmaceutical model? Because we do not find that CBD all by itself, even though Epidiolex exists and is going to help some patients, it should not be the only option on the table. There's some patients that don't respond to it. They need access to whole plant, full spectrum medicine. And so this is, and again, Matt was spot on when he says that it's going to take many, many, many years to be able to isolate each compound and then put them together in various and go through the typical randomized controlled trials. None of us will be here. Our children will be old and gray by the time that happens. So we have to figure out another path. And I know in Israel, they're looking at another path almost as like a nutraceutical or that kind of pathway, because the pharmaceutical pathway is long. It's also very, very expensive. Epidiolex took many years to get to market, and it was millions and millions of dollars. And there isn't time, money, or energy for that. Let's just put that out there. I think in the United States, the reason that we got where we are today is because, you know, frankly, in California, which passed the first medical cannabis law in 1996, it was not left to the politicians and it wasn't left to the physicians. What happened was it was a ballot initiative, what we call a proposition. In California, you're able to have a grassroots effort to get a proposition if you get enough signatures. And it got on the ballot and it was voted for. And it was kind of hoisted on doctors and hoisted on politicians, who, by the way, did what we call, you know, see no evil, speak no evil, hear no evil. None of them wanted to do anything. And that's how California became what I call the Wild West, and what many people have referred to as the Wild West. And we talk about that as a bad thing, but one thing I'll tell you is that in the Wild West, my patients were able to access medical cannabis. The sky didn't fall, a big abyss didn't open and swallow up all of these patients. Okay, it helped some people, and for some people it didn't help, and they moved on to other sources of medicine. But all of the fears that you guys I see that in other countries that are still somewhat behind the states, and even some states, we still have 3 states that have no laws, including no CBD laws, where parents can be put in a jail for giving their children CBD, or Child Protective Services can be involved. But we have many states that have passed laws but still have very poor access. So it's not perfect here at all. But the very important thing to understand is that all of the fears from the whole reefer madness and all of that is unfounded. And I think the only way that you can kind of get the people in power, I mean, that's what this is about, right? There's people in power denying access and denying research. And the only way to do that is from grassroots efforts. And so we have, for instance, a group in the United States called Americans for Safe Access. They get donations. They are relentless. They have gone state by state to change laws and to fight. And how do they do it? They lobby hard. They go to those politicians and they say, your constituents need access. Would you rather people buy it underground and have problems with mold and bacteria or solvents, or would you rather we have a licensed, regulated system? So they hit hard. And I think most politicians have a hard time saying anything against that. But remember too that what has happened here with grassroots efforts, not only from initially in California with HIV and AIDS patients, but the big push by Paige Figge and Charlotte Figge, who everybody knows from Colorado. You know, good luck fighting parents of sick kids. I mean, you're going to get worn down and you're going to pass the laws. So just do it now. You got to keep pushing. Unfortunately, this is something that, I call guerrilla medicine. We have to fight for it, right? NORML, National Organization for the Reform of Marijuana Laws, has played a big role. They make they're politically connected, and they make relationships in the various states' legislatures, and they try to push for, we've been pushing for getting it off the Schedule I. So we still have our own issues here in the United States because it's still a Schedule I drug. And we're hoping that's going to change with the new administration. But if you can make some headway with politicians, hopefully you can start to change the ideas. I have to say that I find neurologists to be the most difficult group to crack. They have to see it, like they have to visually see the child, where the parent says, my child's seizures are reduced by, let's say, like Matt, 85%. And even then it's, there's this kind of disconnect. And that's unfortunate because there's a lot of power there. And I have to say that kind of the only way around that is to get physicians like myself and Dr. Liz and Evan, nothing against neurologists, but I do find that's my group that I have a lot of trouble with. But here and there, I've gotten neurologists to understand that this is just another option on the table. And one of the biggest things that I find is that if I can connect with a neurologist and just share my experience. I mean, I had, I've been a doctor now 30 years. I had a neurologist call me who was part of my training many, many years ago, who called me and said, what are you doing? What is this? What nonsense is this? And I said, you know me, I'm not like some Fruit Loop doctor. I read the research. I'm very careful. I'm a kind of a do no harm. My husband says, you unzip me, there's a chicken inside. I'm very careful. And I'm seeing benefits, and I'm not seeing any damage, like, bone marrow suppression and liver problems and you know, if it doesn't work, we take the child off it the same way we would do with any other medication. If you just treat it like every other medication, it's just a it's the mindset that is very hard to undo. But you know, one of the biggest things is to come up with, you know, and I know you guys are working on this, sensible public health policies based on science, but also including clinical experiences, because if we're not allowed to do the research, we have to include the clinical experiences of physicians and from parents, right? And from those doctors who have used this in our practices. I am not by myself now. Here we have Dr. Liz, and we have doctors in the UK now that are opening up to this. And I'm sure they're seeing what I saw at the beginning of my practice, and I continue to see over the last 13 years that I've been doing this, which is, this is a very benign medication. It is well tolerated. If it's under medical supervision, there's really no reason to fear it. And so that is the idea that we have to get across. And one of the things I might suggest is, you know, within these groups, establish a cross-group panel of experts, get endorsements from, you know, professional organizations. Like in the United States, almost all of the nursing organizations, think about what nurses do. Nurses take care of people, right? They don't have to diagnose, they don't have to come up with the plan, but they are inherently involved and connected to their patients, caring for them. More so, like when when you ask somebody about their hospital experience, they'll say they saw the doctor for 10 minutes, but they were 24 hours with the nurses, right? And then parents are shaking their heads saying, this is our experience. Get endorsements from the nursing associations. That makes a difference. And so, cancer groups that are involved with cancer patients, groups that are involved with HIV and AIDS patients, groups that are involved with epilepsy patients, any kind of group that may, pain support groups that may have some established credentials. I think it's important to kind of build that. And then I do think you have to go to the media as much as possible.
Yeah.
The only way you're going to change minds is to put those stories out there. You put out the stories. And I know Hannah, Matt, and Dom so generously sharing his story today. There's still people who are afraid. There's still people who feel that they might get some repercussions. But notice you guys are out there. You guys are fighting. And there's power in numbers. And there's power when you approach politicians. And unfortunately, it's sad that you have to fight for medicine like this. But in the world where we pour chemotherapy out there and we pour out opiates and we put all these things that are so damaging out there, which have clinical indications, cannabis, I joke around, it's a cupcake compared to this. And again, I am not a kind of fringe doctor. I'm pretty conservative. I'm very careful. And as I'm sure the other doctors on the panel can attest, we really just don't see any harm under medical supervision.
Bonnie, thank you so much. That was really good. I love the concept of guerrilla medicine. I think we need more Che Guevaras in this field, if that's not an inappropriate anomaly. So thank you so much. That was really, really good. I totally agree with everything you said. I'm going to move on quickly because we've got 20 minutes and we've got 17 questions so far. Can I just say, please don't raise your hand because we're not going to take any notice of it. So I mean that nicely. If you can write a question, we'll do our very best to get through 17 questions after Evan's finished. So Evan, again, thank you for helping us to organize this. Evan's pediatric neurologist from Toronto, Neurology Centre of Toronto, and is really very also prominent along with Bonnie in this field, who's been really pioneering in cannabis medicine, obviously in his context of children with epilepsy. So Evan, without further chat, I'll pass on to you if you've got about 10 minutes, and then that'll give us 10, maybe 15, 20 minutes for questions, if that's okay.
Great, thanks, Mike. I'll do my best. Do your
best, Evan. I know you can.
All right. I'm just going to share my screen here. So
thank you.
There we go. Okay. Great. It's an honor to follow those who just spoke. And Bonnie, you asked some whys, and you've got a neurologist here on the panel, as you mentioned. We like whys. I like why questions, and I think Given what I've put together today, I'll probably have it's a nice follow-up because I think I'll be able to answer some of the whys that you posed to the observations and the statements that you made. And then I'm going to finish with a how, because a why is never good unless you've got a how. And I actually taught that to my group this morning. So I'm going to focus on a primary ethical issue here that we see in cannabis, but really what I want to do is invite you on a journey. And where are we going to go? Well, we're going to explore a small part of the creation of you. So the question is, who are you? You're a set of beliefs, and these beliefs have been presented, shaped, molded ever since you were a little tiny baby. The beliefs are actually so fundamental that you don't even know them as beliefs anymore. They're rooted so deep in your existence that you no longer are just this set of beliefs. It's actually your identity, and it's who you know and believe you are. And they are you. Now the question is, where does life take you? Well, the path may take you on to be a pilot, may take you on to be a steel worker, could take you on to be a software developer, maybe a nurse, maybe a doctor. It might just make you become a mom or dad. So now you've added this to your identity. So you're no longer, let's say, Jenny, that diligent pupil. You're Jenny, the successful ad executive, who's a great mom. You might be Doug, the free-spirited student. Who used to be the free-spirited student, excuse me, but now you're Doug, the artist, the painter, who also might be a wonderful dad. You receive praise, you seek praise from friends and your family, from your children, and all of this works to reinforce those labels and reinforce your identity. And the end result is that it reinforces all of your beliefs. And as time passes, and life goes on, and your experience remains congruent with your identity, your set of beliefs becomes rigid and more rigid and more rigid. And there isn't any room for change, because everything you've ever believed has led to where you are right now, which is you. And what you grew up listening to, watching, were told, all of that becomes more and more and more true to you, the Jenny, the Doug, or the individual. And this, everyone, is the birth of your stigma. And you view them as truths, as beliefs because you must, because they are you. But bring awareness to the origin of these truths and this stigma and peel back the layers. And what you're going to find is a set of ideas and a collection of thoughts that really, truly aren't yours at all. So for those here in the audience, on the panel, do you remember these? Right? As a child of the 80s, the 90s, even the early 2000s, like a day would not go by where you aren't exposed or weren't exposed to some sort of anti-drug advertising, whether it be TV, posters, schools, doctors' offices. Just say no, right? There was no other option. And don't underestimate it at all, because fear is a real powerful force of coercion and a surefire way to get anybody to believe something without objecting to it. And when that happens, that belief then also becomes part of you, and it becomes your identity. Now, life is not always fair. In fact, life is never fair, one would say. If it is being fair to you right now, then it's only because it's being unfair to someone else. And so Jenny, that successful ad exec, and free-spirited Doug, who are both stellar parents on different sides of the globe, they wake up one morning and they find that their child has had a seizure. Life stands very, very still for a moment. The seizures continue. With each passing day, their idea of who they are and who they think they are becomes more and more fragile. Their situations are left them vulnerable. The egoic sense of self starts to break down. In an attempt to maintain their identity as the problem-solving parent, they search for answers and then come across medical cannabis for seizures. And then cannabis, they ask themselves, but this is their cognitive dissonance. And either it's their identity that shifts or the world that changes. And we know the latter can't occur, so the former must. And they now have to question who they are, what do they stand for, and what do they believe. And it's in this moment that everything changes. So these moments are rare in life, and they usually follow a pretty significant event. An event with such elevated emotion, it's able to penetrate the wall of thought that is our ego. It could be a first love, it could be a breakup, tragedy, a sickness. And these moments put us in states of vulnerability, which allows us to peer deep into our core. And for a brief period of time, we recognize the illusion. And we see for ourselves who we are. And we see these beliefs as but beliefs and recognize they're not really us and we can change. And then what do? We give an illicit drug to our child. Seizures stop and the world has changed forever. So now I call upon the doctors, the nurses, the pharmacists, the healthcare practitioners here who are listening to think about this. And in fact, I want you to feel this. You're Jenny, you're Doug, see their worldview and feel their perspective. And they come to you now for help. But wait, who are you? You're Michael, that honors student who's now a stalwart of your community as a local family doctor. You're Heather, the academic neurologist with numerous publications under her belt. And every single day, who you have become is reinforced over and over again. With each patient visit, with each successful surgery, all the praise from your friends and families, how wonderful a doctor you are. And society turns around and rewards you for all these labels that you pride yourself upon. You feel super great. You feel reassured. This is all because of what you believe. And you were rigid and fixed in your beliefs, and in fact, more rigid than you even know. Now, one day, Doug or Jenny, they're sitting in your waiting room. When you talk to them, you dismiss their experience. You must. It's the concurrent clobazam the child is on. It's the addition of that ketogenic diet we did 3 months ago. Seizures tend to wax and wane. This is what we know. It couldn't possibly be an illicit drug, something that you don't have any knowledge about and something that you've learned over time, because first do no harm. And all you see in this drug is harm. And this is your cognitive dissonance. Now, at the same time, Doug and Jenny, they no longer see the world like they used to. Now, you, as the healthcare practitioner, you don't fit in their worldview either. You are the closed-minded doctor. You are condescending and unhelpful. You aren't hearing them. This is their cognitive dissonance. Your worldviews couldn't be further apart. And this meeting only works to further divide, to further separate, and to further entrench stigma. But Jenny and Doug, they want their child to be safe. And Heather and Michael, they just want the patient to be safe. But the vastness of this void between is just a result of all that conditioning. And that conditioning is entrenched in our values, our cultures, and thus ourselves and our us. And thus it remains, unless we both bring awareness to this and see each other's sides and work together, will look like this. So the question is, how do we change? Neither side can abruptly change because these are fixed worldviews. So somehow we have to meet in the middle. And this is where I take what's called a harm reduction approach to medical cannabis to help bridge this gap. So the question is, what is harm reduction? Okay. It's an umbrella term that's used for policies and practices that reduce the problematic effects of substance abuse. It was brought in by a handful of practitioners who realized that enforcing abstinence and the war on drugs wasn't working. And for cannabis, I believe that it can be a model that can serve as a compromise for both positions. And this is the model that I believe, and this is the model that I use when I work with my patients with cannabis. It focuses on pragmatism, focuses on harms, the priority of the immediate goals, humanism, and a way to evaluate all this stuff. Here's a busy table, but something to show you a way how it's used in substance abuse and how we can translate that over to medical cannabis. So from a pragmatism point of view, in substance abuse there, the focus on the efforts are on decreasing these harms, not just getting rid of them. So with cannabis, as a practitioner, you got to accept the fact that patients are going to go do this anyway. So by you turning a blind eye to them, you're actually doing harm. And the focus on harms here in substance abuse is trying to decrease negative consequences, not eliminate them completely. And from our point of view for medical cannabis, this is a way that we can say we are actually first doing no harm. We can support people versus dismissing them, and that can focus on the immediate problem, which takes us to the next key principle in harm reduction, which is the priority of immediate goals. In substance abuse, that's where you're focusing on the here and now. What can we do now for the patient, right now, in this very moment? Not a hopeful kind of thought some months, years into the future. And this is the same for medical cannabis. Consider the burden of illness right now for that patient. And if you don't know what you're doing with it, if you have no idea, find an expert, make that effort. And the humanism point, in the substance abuse realm, we value that each individual has this right to be respected and dignified. And same with medical cannabis. We understand this worldview. Now I hope you can grasp where this is coming from the parent and patient side. So they need to be heard. And that worldview, whether you agree with it or not, should be valued. And when it comes to evaluation, this is done on the substance abuse side to ensure the effectiveness of this model, and that can be done easily with medical cannabis. You can offer follow-up and guidance and just follow somebody if you aren't the treating person. Monitor and then see it for yourself. Like Bonnie said, we have to show the evidence. You got to show more and more and more. And here's an example of how we're failing by not using a harm reduction model in Canada. This is astounding to me. We have had access to medical cannabis since 2001. We have had access to oil formulations for all ages, all conditions since 2016. And we've had legal cannabis recreationally and medically across the country since 2018. And still 76% of people are procuring their medical cannabis illegally in a non-authorized fashion. Why? It's a good question. So, in order for harm reduction to work, we need to both work at this though, both patients and families and physicians. And here's a real way, here's a way that we could potentially do that, or some key points I want to bring out that came out of what I was saying today. On the harm reduction side, what can patients do? Patients can continue to educate. Yes, it's frustrating. Yes, it's hard, but continue to educate those around you. Remember the stigma that the others are entrenched in. Recognize your own emotions. Know where they're coming from. They're coming from because of how your worldview has changed and how it comes to a head with others' worldviews, especially those in the medical profession who grew up in this environment which I described and have learned in the environment that I also described. Cooperate with people. Don't reject. Listen. And on the healthcare practitioner side, learn. That's what you can do. You can learn. If you don't believe, you don't understand, then learn. And recognize your own emotions as well. Whenever you feel frustrated with a patient, it's probably because you don't know what you're talking about. Or you are worried that your knowledge of what you're talking about is something that is not up to par with maybe the rest of your knowledge. Prioritize helping and not healing, and practice that pragmatism. On the non-harm reduction approach, these are things that I think patients and healthcare practitioners are doing, which is furthering that divide. On the patient side, there's maybe an expectation that everybody should understand, everybody should listen. But again, remember where it's coming from. Maybe withhold that expectation and transition that into education. Don't act on emotions and anger. It's hard, easier said than done, I know. But that's going to be a real difficult way to convince somebody of something that's really important. And don't dismiss the viewpoints of the experts, even if they are contrary to what you see, what you feel, what you know, and maybe even what's out there. Accept or understand where they're coming from. And that can helpfully bridge the gap. And on the healthcare practitioner side, lastly, don't assume, right? Don't assume anything. Don't assume you know, and don't assume everybody else around you knows. And don't assume the life of somebody that you understand that, because we just don't. And don't respond emotionally. And don't dismiss the viewpoints of the patients. And don't stagnate in where you are in your knowledge. Continue to learn. And I'm going to close with this. This is Jamie. He's a patient of mine. He's a 30-year-old guy who suffered a significant brain injury when he was young. He had some seizures that got under control. And when he came to see me, he was relatively well controlled, but was having a lot of difficulty with any kind of movement. And his quality of life was quite poor. And this was a time where I first started getting into cannabis, and I was okay following people, not so certain about prescribing. And parents came to me and they wanted to utilize cannabis for his quality of life. And I had never really discussed that or been approached with it at that point in time. It was always for seizures or something specific. And I hesitated, but in the end, again, realized where these patients come from, realized what Jamie's life might be, and said, well, I don't know how comfortable I feel, but I'll watch this. and we'll do it in a safe way. And 3 years after using medical cannabis, this is Jamie, who wasn't able to walk and is now able to walk by himself on this treadmill, holding on and out of his chair. Pretty amazing. And if I had stayed entrenched in my stigma and my disbelief and allowed myself to be there, not been vulnerable and open, then possibly, perhaps, Jamie would still be in that chair, or very likely parents would have gone and done it anyway. But now they have the oversight of a neurologist. I have one more case under my belt and can see here what he needs. So in the end, okay, when it comes to considering novel therapies, new ideas that move against all of our beliefs, let's not put our heads in the sand. Okay? Let's recognize that we all want the same outcome. A mom or dad doesn't want their child to be sick. A healthcare practitioner doesn't want that child to be sick. And we're working together towards a common goal. So let's build that bridge together. Thanks, everybody.
Brilliant. Yeah. Devon, thank you so much. That was a wonderful set of slides and really, really good. Thank you so much. And thank you to everybody, to Bonnie, Liz, Dom, and Matt. That was a great series of talks. As a result of that great series of talks, we've only got 4 minutes left. So what I'm going to suggest is we go through the questions and we overrun till 7:45 if people want to know. Obviously, I realize some may have to disappear, but let's plow through those questions quite quickly if we can. And I'm going to read them out and the panel will chip in. Some we've answered as we've gone through. So let's just go through these one by one. The first one, I'll just start at the top. I don't think the audience can see this, so I'll read them out. For the clinicians on the panel, from a bioethical perspective, how do you modify your informed consent process when you're prescribing a product, a combination of cannabinoids, for which clinical efficacy for several conditions hasn't been fully elucidated, and for which medication interactions are oftentimes unknown? So I don't want to go into these very quickly, so no long answers, please, about 30 seconds on each. So anyone like to plow in on that one? How do we modify our informed consent process? Bonnie.
I'll just tell you, I have a specific informed consent. It's about 5 pages long, and it says it's not FDA approved. It says it may be contaminated. It says all kinds of things, everything under the sun that can possibly go wrong. And then there's also I've been able to ask questions and have my questions answered by the physician. And a lot of people don't sign that until they speak to me, right? So we have that informed consent up front, and then we answer the questions. And remember, most of what might be negative is really related to THC and overuse of THC or abuse of THC. It's not usually related to the other cannabinoids that we're including in medical cannabis.
Yeah, I actually think I'll say you don't have to modify your informed consent process one jot, because informed consent's informed consent. You talk to the patient, you involve them in the process, you explain what the medicine is, explain it, licensed or unlicensed or whatever. You just talk to the person. It's not some sort of magical process. So I think the answer to that is you don't modify it one jot.
Yeah, I agree. I think you just explain. Patients that we prescribe a medical cannabis for, this is a drug of, as Dom's evidence, it's a drug of last resort at the moment. People have already, been through a process, and it's just explaining what an unlicensed product
is and
exactly. Making sure so carefully and titrate it, start slow and go, start low and go slow, and just do it as you would any other medication.
Exactly. Yeah. Quick one for Dom. Did you struggle to find the correct cannabis medicine, or did you find relief from all that you were provided? Dom,
okay,
you answer that as a quick summary?
Absolutely. Can everyone hear me okay? Yep. Right. So
yes,
I initially smoked it raw, as it were, when I was weaning off the codeine. Then I experimented with dose sizing, believe it or not, vegan cookies. I decarboxylated it myself, diffused it in coconut oil, and then cooked it into cookies, because I found that ingesting it caused the effect profile to last a lot longer. So when I saw the doctor, we started out on I think it's Althea Rideau, which was 1 in 20 THC CBD, then on to Capilano, which is a 1 in 1, I believe, and then I'm now on the Champlain 20 0, so it's 20 milligrams THC, 0 CBD, and I have flower similarly strength for breakout pain. It was an iterative process, but I wanted to do it the right way, and that is to titrate onto a therapeutic dose. So yes, I would say struggle, yes, but whilst I was getting stabilized on the oil, I was using cannabis illicitly, and in between having cannabis oil, legally delivered to me, particularly during the first lockdown, because obviously there's supply problems.
Okay, Tom, thanks. Daisy's asked, I'm the mother of a 10-year-old with drug-resistant epilepsy. We're about to start medical cannabis through a private clinic. I've read Bonnie's book, which is fab. There you go, Bonnie. It's a good advert for you there, for your book. I'm interested in where we are in this country in terms of what we're entitled to information. Is there an obligation to provide some sort of certificate of analysis? I asked the pharmacy, and what is in my daughter's prescription was told they cannot give information. But if they told you that, find another pharmacy. That's totally wrong. You have a total right to know what is in the medicine that you're taking or your child is taking. And if they don't provide it, they will have a certificate of analysis. Tell them to give you the certificate of analysis. If they don't like it, tell them to get stuffed and find another clinic. So there you go.
Can I just jump in there really quickly?
Go on in.
There's only the legal requirement in the UK is to only show CBD and THC. What Matt and I are doing with MedCann is to try and ask for transparency from all UK suppliers. So CBD and THC is not the only medicinal parts of that product. So we are trying to do that through MedCann and Drug Science and the Society to try and make sure that we are absolutely getting a full COA for all products, because that's the only way you'll know whether it's safe. And like Matt says, if you get an AED from a pharmacy, you know what's in it, the whole thing. Any medication from a pharmacy, you have an insert that tells you what's in that product, and you should insist on the same, because unless we do, things won't improve. So exactly what Mike says, but we're trying to work on that, because it's not not easy at the moment.
It's important. Lewis Cameron, what does full spectrum oil look like in terms of THC versus CBD versus the rest? Is it fully standardized? I don't want to answer that. That's a big answer to that question, but
well, it's not fully standardized in the sense that batch to batch isn't the same with a full spectrum product, but actually in my experience and Matt's experience, I'm sure, and in Dom's experience, as long as there's only a 10% leeway, it actually doesn't make any difference to the patient. And actually a full spectrum product is far more effective in my experience and many other patients' experience than these isolated cannabinoid products where they're distillates and isolates all added together. They're not as effective in our experience. So actually I think the fully standardized thing isn't an issue as long as there's only a 10% leeway.
Yep.
And also, there are differences in THC. Sorry, I was just. There are differences in THC and CBD in the different products, and they're quite clearly stated. And yes, there might be a slight leeway with the amount, but when you're prescribing, you do know, each individual product is different.
Yeah.
There's no standardization.
Yeah, exactly. There's a couple of questions I think we've answered as we've gone through. So if I ask you a specific question, I think we've sort of answered it as we've addressed the talks. One here, does UK have any equivalent to FDA's orphan drug system? I actually don't know the answer to that. Certainly cannabis hasn't followed an orphan drug route. Do we have an orphan drug route in this country? Anyone know the answer to that question? Or shall we find out and come back to you, Shelley?
Find out.
We'll come back to you, Shelley, because there's an anonymous silence there. I don't think so, but I may be wrong, and forgive me if I am wrong. Next one, anonymous. Observational studies around data from patient notes. Yeah-ish. Is cannabinoid use captured by physicians or still taboo? Also, in rare disease and rare oncology studies, intrapatient approaches are taken. Has this been looked at? Difficult to answer that quickly. But observational studies don't fully or totally rely on patient notes. They there's all sorts of ways of conducting observational studies. We need to be very open about there's N1 studies, there's observational studies, there's case studies. There's lots of ways of doing this, some of which do rely on screening and summarizing patient notes. And that's the sort of work we should be doing. That's the sort of work that NICE and others should be recognizing as it's a phrase these days, but real world evidence. It is real world evidence because it's real evidence. Yeah, Liz.
I was just, yeah, I mean, obviously there's a difference between that as well, but basically, if as a prescriber, you know, I send my letters to the GP, and I won't prescribe unless my patients agree for me to inform the GP that I'm prescribing medical cannabis. And I also assess the symptoms, and each time I see that patient. So the notes are there. There's no, I'm not hiding anything, and the patient shouldn't be.
Yeah.
Either, because they need somebody that's trained in prescribing medical cannabis, who's prescribing a medication and is following them up exactly the same as any other medication. We've just got to take this away, you know, this sort of stigma. I think what we need to take the making cannabis different from any other prescription of a different product away, because I think that's what's causing this harm.
I agree.
But the information's there, and I've never had any problem accessing the patient.
Yeah.
You know, GP records and things prior to prescribing, and their GPs have got all of my letters as well. So I think that happens anyway.
Thanks, Liz. Jennifer from Winnipeg in Canada. I'm a family physician who has a consultant pediatric cannabis practice for 3 years after my son with intractable epilepsy completely turned around on CBD. A lot of initiatives here and in Canada to push research and support these kids. Good. Here in my province, I'm working with government to change policy regarding children having their medical cannabis in schools. Being a parent and a physician, we are trying to change things for our kids here. I try to advocate and educate colleagues about how much of a difference this can make, not only a child's life, but the whole family. So good, it's not really a question, it's a statement. Great, we need more physicians like you, Jennifer, who are prepared just to push the boundary, push the local politicians, get in the media if necessary. Bonnie is very true. And sadly, politicians respond to media pressure and not academic intellectual pressure. Okay. Anonymous, some drugs have been approved based on titration for individual patients. Is it possible to select the therapeutic target and to focus on stable full spectrum with only titration of THC or CBD based on the specific therapeutic target? Sorry, I lost the track of that one. THC titration for pain and CBD titration for epilepsy. Evan or Bonnie want to answer that one?
The answer is yes, this is how it should be done.
Yeah, exactly.
Right? And one way to look at it is cannabis is I think was alluded to on the panel here, is not one medicine, it's multiple medicines in one. So
yeah,
you got to focus on the individual cannabinoids, and
yeah,
a practitioner with knowledge will know how to do this.
Okay, another one from, there are huge companies that own these cannabis clinics. Untrue, they're not huge companies, but they seem to be expanding more quickly than the product imports can keep up. Also, I'm sorry to say, I'm sorry to disagree with Anonymous, but that's not true either. As an adult patient, it feels like we are guinea pigs paying large fees at the whim of the pharmacy now. Also not true. There's a real fear to report issues with the clinics. I hope that's not true. If there's issues with the clinics, tell them. Because the status of cannabis in the eyes of the NHS and government. How do we ensure the clinics and pharmacies are actually keeping patients and their needs at the forefront? I'm sorry to be blunt. I can be blunt from time to time. Most of that isn't true. It's the companies, not huge companies who own these clinics. They should be like any other clinic at all. If there's a problem with a clinic, tell the clinic. All the clinics have to have complaints processes and procedures. The CQC oversee them. If they're not doing a proper job, tell them they're not doing a proper job and they need to deal with it. There's no cover up and there's no people paying large. I totally agree with you that we shouldn't be providing this through the private sector only. I'm absolutely 100% about that. It should be on the National Health Service. It's sad that it is. That's all I want to say on that, really. If anyone disagrees with that.
I just wanted to jump in with regard to pharmacies. We know there is issues with supply. We know that. We know there's issues with some pharmacies. Again, you need to tell them and you need to complain about it and you need to talk about it, because it should be treated like any other medicine. And Matt and I have talked about this before. If you have a prescription, it should be dispensed like you do with any other medication. It's not acceptable if you're paying for medication and you're not seeing it for weeks on end. That's not good enough, but you should complain. You shouldn't worry about the fact that again, as Liz says, this should be treated as any other medication. And if the service and the patient journey is not acceptable, then you need to be talking about it and you need to be complaining. Because that needs to be better, and it will only be better if people talk about it.
Yeah.
Quite agree.
I do think there is I do think it must be very difficult from patient point of view into applying products, and it's also frustrating from a prescriber point of view, because there is no doubt there is a lot more products available in the UK now, but it does change. So, you know, for example, there was one particular indica flower which was available, and I prescribed it for quite a lot of my patients. It was very effective, but then that's out of stock. So then now I'm having to change what I write on the prescription. So the patients are still getting the same type of product. They're still getting a THC dominant indica flower, but then there's a delay, because then you know I don't know if it's run out. So there is this sort of inherent delay, and I think one of the challenges is you know all of the doctors are also doing other jobs as well, and we're getting asked to change prescriptions, and then often sometimes we don't know about the product supply problem. Obviously Brexit affected the Bedrocan products, and there's so much going on that actually if so then that unfortunately has an effect down the line on the patient. And what from my perspective as a doctor, it has to be all about the patient, but it's such a weird, unique position that we're in currently. And if it is, if we do get to that point, which I do hope, that is available on the NHS and it's stocked in pharmacies, so we know exactly what's going on and what you can prescribe. I think that would be better, but I think the communication's improving a lot. So now, before I prescribe, I know what's in stock, so I hopefully can prevent those problems for the patients. But it's still so expensive, it really is.
I think that's the thing. We have to remember that you've all been, and we've all been at the beginning of an emerging embryonic industry, and there's going to be lots of teething problems. And sorry to clarify my point, there's no blame to doctors, but I do think that the pharmacy side of things and the clinic side of things, the communication hasn't been as very, always on par with patients and always on par with the people that work for them either. So there is things that need to improve, but we have to remember we're at the beginning of something in this country, and as time goes by, it will improve. If we all try and make that happen, it will get better. But patients are the most important thing here, and they, we have to ensure that people are treated with respect, and that money is taken from them when products is available and things like that, and that sadly hasn't always been the case.
I think one area that I think will improve access, will have to improve access, is the chronic pain. Is quite interesting what's happening, because the comes out, which is again pushing people away from opiates and away from benzodiazepines, but what's the option? And if you look at what's happening in America and in Canada about the opioid, a lot of the prescribing of cannabis, and people are sort of acknowledging of it as a substitute to get people off opiates, but still be effective for pain. I think that's some of the way that it will get more accepted in the UK. I hope that that's another way in for the cannabis as well.
Okay, we'll move on. Is enough done to promote the safety profile of cannabinoids with physicians? Is enough done? It's a difficult question. I think those physicians who are prescribing in general, I'm not sure every physician prescribing is fully aware, but most are. And I think those who are properly trained in cannabis medicine will obviously mention the safety profile as well as the positive side. They mention the potential negative side, I think. I'll move on. Let someone else get an answer in. As a follow-up, I've been told by my daughter's neurologist that we should view medical cannabis as just another drug. Sorry, something's moving this. But another raft of drugs that work on a system in the body that's only recently been recognized. Am I right in thinking that, like existing AEDs, there are many, many products to try? If one doesn't work, as patients or parents, if we know that one hasn't worked, it doesn't mean there isn't another one out there that will. That's why it's so important that we have access to information on what is in our children's prescriptions. Thank you. Anyone
I'll just say today, Matt, do you want to comment on that and talk about why MedCann's important for people?
I completely agree. That's one thing that is completely missing at the minute within the UK, is that, talking about exactly what's in the product. And that's, as Hannah's already mentioned, something that we're really starting to fight for, working with PLE, with NCCS, with drug science, and we're going to start hopefully just pushing it out there and saying, as patient groups, this is what patients are screaming for, and it's only going to aid clinicians as well. So just talking about CBD and THC, that's a tiny part of the story. So the more we understand about the full phytocannabinoids and the terpenes, we can start looking at data, we can start gathering data through drug science, we can start building a picture. And all that evidence can help move things forward.
Bonnie, did you want to add something there? You had your
Sure,
hand
I
up?
just wanted to say, I just wanted to say that if one, let's say, high CBD, low THC ratio product doesn't work, that does not mean that the other products won't work. I have patients trying multiple different products from different companies. Remember, these are plants. They're not made in factories. These are plants that are grown, and they have different amounts of the varying ingredients. And what we're trying to do is match the chemistry of a plant to somebody's very complicated neurochemistry. That's very difficult. So I understand that it can be expensive to explore. By this one, it doesn't work, by that one. And that's a big problem here. I find that parents start to think, oh, I'm wasting my money. But if you've tried, I usually tell people, try at least 3 or 4 high CBD, low ratio before you give up. And of course, in California, we have other products, which I would encourage you guys to fight for as well. Don't just fight for high CBD or high THC. THCA is incredibly helpful. I see it helping so many of my patients. Low doses work. I've seen CBDA work beautifully. Low doses, inexpensive. And also CBG. I've got patients who never spoke before who are speaking because we added 2, 5, 7 milligrams of CBG to their cannabis regimen, and it's changed everything, including an adult who was not speaking other single words is now talking in sentences after CBG was added to the regimen, which it's hard to think it was a placebo or not involved because she didn't speak until that was added for 34 years, I think, or 26 years. We have to understand that it's not just CBD, and there are other compounds, and that can help give you better results.
Yeah. Thank you, Bonnie. Very true. And from Nora, thank you for allowing me to join. I'm a patient now. You're very welcome to join, Norma. Welcome. In the US, from Anomaly, is it generally prescribed by physicians as a standard option? If so, what do they prescribe? Full spectrum, question mark. In the US, is it generally prescribed by physicians?
So in the US, there's no such, there's no such thing as a prescription here, because it's still a Schedule 1 on our Controlled Substance Act, which is the act that says it continues. We still have in the United States cannabis in the schedule that says there's no medicinal value, high abuse potential, and lack of safety, even though we all know that that's not true. I could say that about alcohol and tobacco, which are not even on the schedule. But so there's no prescription. I am allowed to give a generic kind of, I've evaluated this patient, I've reviewed their medical records, I believe that they will benefit from the use of medical cannabis, and that is what they get as their legal document stating that they are approved. And remember, each state has their own method of doing this. In California, I can give the patient the letter and they can go get their medicine. In other states, most states now, you have to apply to the state. The state gets all their paperwork, you pay a fee, and then they issue you some type of medical cannabis approval card. And remember too, though, that we have states that have legalized, similar to Canada, where anybody over the age of 21 can walk in and get what they want. There are surveys showing that something like 60 to 70% of people who do not have a medical letter, who are walking into what we call recreational or adult use dispensary, are actually seeking medical cannabis.
Thank you, Bonnie.
Just anecdotally, I did exactly that in Jamaica in February last year. They have dispensaries in Jamaica, and I just went in and said, look, I don't have a prescription, I don't have my medical records, but you know, I've got this pain condition. Here I am, and they supplied me with effectively medical grade cannabis without any issues whatsoever, and very inexpensively.
Yeah. Thanks, Tom. We've got about 5 more questions if people want to know. We're down to 75 people, so people are going to drop out. So I'll do this very quickly. What are the 3 main constraints in the UK in utilizing the use of medical cannabis? That's a long answer, Charles, but I would put my 3 as lack of education, poor guidelines, and lack of understanding by senior medical bodies. Anyone want to add to that? Liz? No?
Yeah, you've summarised that in a nutshell.
Yeah.
Thank you. And Josie Dawson, I'll paraphrase that quickly. Basically, Josie is saying here that kinesiologists should be able to prescribe, and others. She says that many medical practitioners aren't holistic. I agree with that. And I also think that particularly in the first general practitioners, and if I can crudely summarize, I think general practitioners will be very good prescribers of this medicine who tend to deal with a whole range of symptoms, whereas specialists tend to be diagnostically orientated, with a lot of exceptions. So I agree. I think a lot of other people should be prescribing this, but at the moment, the law says it says doctor on the specialist register as the primary prescriber and a general practitioner or other doctor as a follow-up prescriber, if you like. And that's the law at the moment. And what we do is try and change it. So I agree with you, but we can't do anything about it at this moment. One route, no, three more. One route would be pharmacoeconomic studies looking at cost savings using cannabinoids. There are publications, but not seeing the effect of cost savings. This will maybe promote government sponsors of studies. I totally agree. Anyone want to comment on that? We absolutely desperately need pharmacoeconomic studies.
Yeah. There is a study that was done in 2015 by a father-daughter economist group that found that one of our, we have Medicare here, so once you hit a certain age, or if you cannot afford insurance, that's kind of like equivalent to NHS, I suppose, where it's government-sponsored medical care, which a lot of people don't realize it's government-sponsored, but that's another issue. They reviewed charts to see who was switching from and the cost of adding medical cannabis to a regimen, and they found significant cost savings. And it was related to pain, anxiety, epilepsy, nausea, insomnia. Those were, I think, the main 5.
Bonnie, could you send that to us? Have you got a link?
I will absolutely send that to you.
Thank you. That'd be great.
Thank you, Bonnie.
There is also Dr. Kelly Seaman.
Yeah, I agree.
That there is a study in refractory epilepsy showing the cost effectiveness of cannabis versus AED.
All right, good. We certainly need more of it. I think whoever wrote that is right. The government listens to economic arguments. Media first, economic arguments second, and science third.
It wouldn't be that. I think I think a lot of it is about collaboration, isn't it, and about everybody feeding into these types of economics. There's there's lots of our patients that there's so many people come off medication, and the majority of my patients reduce at least 1, if not 2 or 3 or 4 medications when they're on cannabis.
Exactly.
And they're all high cost. They're all none of them are insignificant costs when you add it up.
Yeah.
So I do think that is a good point. It's just making sure. It's just how it's just coordinating these types of studies. Isn't it?
Yeah.
Can I chime in? Can I just ask Evan if you've seen that in? Have you seen that in Canada? Some cost savings?
So there's no studies that I can direct to that we've looked at that I'm aware of. We have data in drug-resistant epilepsy, which is very good, not medical cannabis stuff. So we have a whole dearth of really good economic analyses on the cost of drug-resistant epilepsy. So that's all there. It would be nice to look at, currently with cannabis, and then use that kind of old data and compare. So it's there.
Sure. Thank you.
Yeah. Thanks. 2 more. I'm sorry to say I don't understand this one, but someone does. Evan, does reaching ego death affect a patient's mental and physical condition? Evan, do you want to answer that? I don't understand.
I think this individual might be confusing psychedelics with cannabis. So
okay.
Is a term for what may be achieved in certain doses of psychedelic medicines. So it's important to know, though, cannabis does have some quasi-psychedelic properties to it. It means that it can elevate, or it can elevate whatever kind of mood one is in. But it does not does not work in the same mechanism by which the psychedelics do. So you should not be experiencing that using cannabis at all. And if you are,
thank you, Evan.
You should ask for your
yes. I'm going to finish on this last question because it's a nice finish, because Australia is a couple of years ahead of the UK, and Australia has now tens of thousands of patients for cannabis now. I think politically they will hold it back until we have a newly managed NHS. That may be the case, but I'd like to finish on a positive note that Australia, only being a couple of years ahead of us, has tens of thousands of patients, and I would like to see in the UK, if we do this in 2 years' time, we'll also see tens of thousands of patients who deserve this medicine. So on that note, I'd like to thank the panel. I'd like to thank the Nhs Cannabis Society, MedCann Support, the Jamaica Medical Cannabis Corporation, Evan for helping us out, and our speakers tonight. It's been a great evening. I apologize for overrunning by 25 minutes, but I think we've dealt with all the questions. And thank you all very much. I wish you a very good evening, afternoon, or morning, wherever you are. So thank you for joining us, and hope to see you next week.